Hello, everyone. Welcome to our 2SLGBTQIA plus competency series. While everybody's joining, if you want to go ahead and drop your name and organization in the chat, and we'll get started in just a minute or so. Hi, Erica. Welcome. Becca, Mary Kate. I see some names that joined us on Tuesday as well, so that's wonderful. We also have our 2024 webinar series, which is the third Tuesday of every month. So make sure you sign up for that as well. That's a different registration link. And then this series is a 5-part series that'll run the third Thursday of every month from January to May. So if you're just joining us, if you want to drop your name and organization in the chat, I'm going to go ahead and go over a few VNPC announcements, and then I will turn it over to our amazing guest. I'm Lauren Gonzalez, a communications manager for VNPC. First up, make sure you mark your calendars. March 17th through 18th is our Day of Learning. It's at the Westin here in Richmond, Virginia. We have a brand new event registration platform launching that's awesome. So registration will be open early February, but make sure you go ahead and mark your calendars. And then if you didn't get a chance to look at it, our 2023 annual report is available. It's on our website on the About page, and Tiffany's also going to drop the link in the chat. Definitely take a look at all the work we did last year. We have some awesome QI initiatives going on. So Project Embrace and EBDC, Eliminating Bias in Dyad Care. I think Brittany Watson's on the call here. If you're not involved in a QI project with us, definitely reach out. She can drop her email in the chat. And then in addition to that, we're standing up our governance. So board of directors, we have 3 different advisory committees, and then we have a VACE roundtable that everybody's invited to. So there's a governance interest form. If you all want to get involved with VNPC, definitely fill that out. General Assembly season is upon us. We are tracking quite a few bills that VNPC is mentioned in. So Tiffany's going to drop the bills that we're tracking, the link to that in there. You can definitely check them out, follow along. All of the House and Senate committee sessions you can live stream. And then we have a hospital recognition program coming soon. So more information on that will be available probably in the next few weeks. And this recording for this webinar will be available on our YouTube channel within the next 48 hours. So if you registered and your friends aren't able to come, let them know that it'll be recorded and they can find it on our YouTube channel. So without any further ado, our title for today is 2S LGBTQIA plus 101. Lots of good information is going to be available. We have an amazing guest with us. Featherstone is a dual certified nurse practitioner of women's health and psychiatry. They are passionate about the mental health of parents and LGBTQ plus folks, reproductive justice, and health education. They founded Eucalyptus Health in 2020 to offer psychiatric and sexual health care via telehealth to teens, parents, and adults in Idaho and Virginia. Featherstone, I'll let you take it away.
Thank you so much, Lauren. You'll all have to excuse me. I'm recovering from the flu, but I'm really excited to be here. And I'm really excited to see a lot of familiar names, especially from Bon Secours Memorial College of Nursing, which is my alma mater for my undergrad, and several nurses that I've worked with in the past. So that's always really exciting to me to see people that I've known and appreciated from the community who are interested in these sorts of things. Because often throughout my career in particular, I had several years in labor and delivery and mother-infant unit when I was in nursing school, where I found that the focus was very narrowed. And there was very much an expectation that everybody coming through labor and delivery was cisgender, straight, in a relationship with a man. And that just simply wasn't the case for a lot of people. And so we have to know who our patients are to understand how they move through the world. We all know that social determinants of health are really, really big and important. So that's going to be touched on throughout this presentation. Many of you may have caught a presentation I did on perinatal mental health in the queer community. I think it was mid last year. But that's sort of what sparked our conversation that led to this today, was because there was so much information there that people weren't familiar with that they couldn't really grasp it. And so Shannon and I had this discussion and developed this series so that people would be more competent in all kinds of queer related topics, so that they would be able to talk more confidently with their patients, understand where their patients were coming from, and provide better care, whether they're healthcare providers, whether they're mental health, whether they're with Medicaid or WIC, or wherever else they are in the community interfacing with families. I have no relevant financial disclosures. I have some really brief objectives here about reviewing concepts like sex, gender identity, gender expression, sexual orientation, and terms like transgender, cisgender, non-binary, two-spirit, and intersex, things that a lot of us have a vague concept of.
Just
Yes.
want to make sure, are you sharing your screen?
I am not. Thank you so much. Thank you so much, Tiffany. I'm the
No
worst
problem.
about that. Okay, these are our brief objectives. And really the last one is the biggest thing. It's to talk about how we talk with patients so that they feel understood and comfortable. My favorite thing to start these presentations with is something called the genderbread person. It really always tickles me because it's such a cutesy graphic, but I feel like it really helps people remember because it's so contrasting to what we usually see in like healthcare education. And it's this really lovely little graphic, and it sums up so much of these really intangible concepts like gender identity, and it has the multicolor brain, and the attraction is the heart being like who we love, sex being, you know, genitals and hormones and chromosomes, as well as gender expression being like the outside of us and how we present ourselves to society. This graphic is regularly updated. This is actually the version 4. And I believe his name is Seth, has this trademark, but the website it's pronounced metrosexual.com if you're ever interested in an updated version. This is where it sort of breaks it down. And not all of this is necessarily things that we need to be digging deep into. But it talks about, instead of things being on a linear scale where male is on one side and female is on the other, it shows that there are two different sort of vectors that people can travel across, as far as like how feminine their gender is or how masculine their gender is. And gender is all about how people conceptualize themselves, how they fit into society, how they want people to treat them, who they fundamentally are. And then gender identity is not always congruent with gender expression. Gender expression being how we dress, whether or not we wear earrings or makeup, or we wear boots, or if we wear high heels. And so there can be a mix, and having these two separate pieces shows that there's not a strict dichotomy. It's constantly an influx balance. And I think the centerpiece right here, where it shows that identity is not the same as expression, is not the same as sex, and is not the same as orientation, helps us recognize that these are all separate but interconnected concepts. And then more recently, the LGBTQ community has become even more granular in differentiating between sexual and romantic attachment or attraction. And so identifying whether people are or are not sexually or romantically attracted to different genders or presentations of people may or may not be relevant to a lot of the work that we do with families, but it may help when we're seeing couples and they may appear heterosexual on the outside, and then realizing that one or both partners is queer or transgender, and how that might add nuance to how they move through the world and how other people may interact with them. I also want to encourage people to ask questions as I'm going, because, or to put them, I think there's a Q&A section, correct, Tiffany?
Yes, absolutely. Please place all questions in the Q&A. It's a lot easier for us to see them and ask later than if you plug them into the chat.
Okay, great. Because I know people will come on later and add themselves.
Yep.
Great. So I always start with the joke of we're going to break down the alphabet soup, because I know that the 2SLGBTQIA plus acronym is really long. Some people just stay with LGBTQ. I think the plus at the end is really good for all encompassing. But there are reasons why it evolves. And part of it is because there's an awareness that there are other identities that are sort of being named and identified, and we don't want them to be lost or ignored or overlooked. And so part of why I started with 2S is because 2S is for Two-Spirit, which is a topic that we often don't talk about often at all. And so because it is culturally linked, it is related to like Indigenous North American people. It's a distinct gender from male or female. Because there's so much intersectionality with other cultures and groups that it's good to, my words are escaping me, highlight where there are more nuanced identities. And then some of the more common parts of the acronym that people are more familiar with is lesbian, or a woman who is sexually attracted exclusively to women. The G is for gay, any person who is sexually attracted to people of the same gender, so that can be man or women. B is for bisexual, and I will be clear that since there has been more and more awareness of gender being less of a strict binary, there have been people who have started to interpret bisexuality to be someone attracted to two or more genders, because there is more than just male or female. The T is for transgender, anyone who identifies as a gender different than the sex they were assigned at birth. The Q is often for queer, or any other person who is not exclusively heterosexual or cisgender. I will say that queer is often a term that I default to. I feel like it's a term that has historically been pejorative, but has sort of been reclaimed by current queer culture and the 2S LGBTQ community. Some older people will find the term queer offensive because it was used pejoratively, but for a lot of younger people, it is much more commonly used. I is for intersex. We're going to talk about intersex a little bit more in a bit. The A can be for asexual or aromantic, someone who does not have inherent sexual or romantic desire or interest. And then some other terms that you might hear would be like pansexual, meaning attracted to all genders. Genderqueer is another one that's not in the acronym, but a commonly used term. Genderqueer is usually related to like a non-binary gender, or someone who does not identify exclusively as a man or a woman. Agender is someone who doesn't identify as having a gender, but sort of being separate from those categories. And terms change, you know, it's a part of a culture, and culture evolves over time. So don't be afraid to Google things that you hear and do your own sort of research when you're confronted with something you're not familiar with. Because there's no way that we can constantly stay abreast of something that's so rapidly changing. And so part of this is not just cultural competency, but cultural humility, knowing that we can't know everything and that we have to keep learning because society is ever evolving. I wanted to talk more about intersex because, especially from a background of working with families and pregnancy, Intersex individuals are more common than I think people realize, but they also have some unique complications as far as pregnancy and fertility that are going to be relevant to a lot of the providers here. There's an estimate that intersex people are at 1% to 2% of the population, but not all intersex people will know that they are intersex, especially people who never try to become pregnant, because they may not be aware that they have both a combination of male and female biological traits. So this can be chromosomes, genitals, or hormones. So for instance, people can have both testicular and ovarian tissue. People can have underdeveloped uterus and ovaries and have like a higher amount of testosterone in the body, like naturally. And so there are intersex people who have a uterus and ovaries, and they ovulate and they're capable of pregnancy, but they may need more fertility treatment because their hormonal milieu may be different. They may not ovulate regularly, or they may have a smaller uterus, and so their risk of miscarriage or preterm birth is much higher. When you look at the pregnancy outcomes of intersex people, there are much higher rates of miscarriage and much higher rates of preterm birth. And so we all know that higher rates of miscarriage and preterm birth are really big risk factors, not only for outcomes with babies, but outcomes for mental health of parents. And so these are things for us to be aware of, both as medical providers and as other people working with families. When we go into talking about sexuality, I want to make a note here about these may be really foreign concepts, but agential versus behavioral identity. So when we talk about agential identity, it's what I call myself. It's I say that I am bisexual, or I say that I am heterosexual. But there's often a discrepancy between the label that someone gives themselves and the actual behaviors that they engage in. We have a lot of people who might identify, let's say, as lesbians, but they didn't use IVF. They ended up having sex with a man to become pregnant. It doesn't mean that we get to tell them they're not a lesbian. It just means that we can recognize that while we identify a certain way, in the research about like STIs in particular, we've seen a lot of discrepancy between people's behaviors and what they use as their label as far as their sexuality. Truth of the matter is, sexuality is often fluid, and people's labels and behaviors can change over the course of a lifetime. It's not to say that we challenge people's labels or reduce sexuality to a phase. That's a really offensive way to reduce someone down to a phase. But just to acknowledge that sexuality on its own is complex and tends to evolve. It also means that for sexual health providers, it's important to be really granular in a history taking and to ask about the types of partners that a patient has rather than their label. So saying things like, do you have sex with people with penises? Or are any of your partners transgender? Things like that can give you more information rather than, are you straight or are you gay? Like those are very reductive terms, and they also don't give you much relevant information as far as health. Pronouns are always something that people who are not in the LGBTQ community can really struggle with, and they can make people uncomfortable. I've seen really, really well-intentioned people like stumble over pronouns in a way that makes everybody uncomfortable. So I want to sort of forgive everybody in advance, and say that like pronouns get messed up all the time, even by people in the queer community, and it doesn't have to be a big deal. Effort and intent is really important here. Making a habit out of offering your pronouns as a part of an introduction. Hi, my name is Featherstone. My pronouns are they, them. How do you like to be called? opening the door, letting them say how they like to be referred to. And if they want to add their pronouns in kind, they can, is a very comfortable way to introduce yourself to people and making it safe for them to do so. Even just acknowledging that their name on their chart might not be the name they want to go by, and that you did not assume that their pronouns were anything in particular based on their chart. Don't only ask for pronouns when you suspect that someone's transgender. People will pick up on that, and it's tends to be very uncomfortable. You cannot tell if someone's trans necessarily by the way they look. So it's always better to just ingrain this as a habit that you do for everybody. Hi, my name is X. My pronouns are X. What do you like to be called? Is a really, really easy formula. And just keeping in mind like gender inclusive language when we're in like a birth environment. Instead of saying something like, who's the baby's father? Go for something like, who are the parents? Or who's going to be involved in taking care of this baby? Don't assume that everybody who gives birth is wanting to be called a mom, whether they look feminine or not. Don't be assuming that any masculine person in the room is the father or wants to be referred to as he or him. Part of this is just recognizing that we make many assumptions when we work with people on a day-to-day basis, and some of it is functional, but some of it can also be a hindrance to us developing a authentic relationship with the people we're caring for. Misgendering mistakes happen. We slip up on pronouns. The best thing you can do is immediately say the correct pronouns and then move on with the conversation. If you want to apologize, it may just bring more attention to the slip up and more discomfort. If you want to apologize, my recommendation would be to not do it in front of any additional people and to do it offline. A more common occurrence is that people are using combinations of pronouns. So you might see in like an email signature, she, they, or they, he, or she, he, they. And usually those combinations are more to express like gender fluidity. And they are usually presenting the pronouns in order of preference. So the first pronoun is usually the one that they prefer to be used more, but the hope for people who present multiple pronouns is that you will use them interchangeably. No one's going to get mad if you only use the first one, but that's like pronoun 201 is like alternating between the multiple pronouns. Lots of folks always have questions about gender affirming healthcare. And I'm just going to really quickly review like transition and gender affirming healthcare, because a lot of this isn't necessarily relevant during pregnancy. It's more about it stopping during pregnancy or being harder to present the way one desires to when there's a lot of uncontrollable changes happening in the body. Transition, as far as transgender folks, usually falls into the following categories. It's social, legal, or medical. And so social is like changing how people dress, changing their pronouns, going by a different name, wearing makeup, wearing like clothing that's more associated with a different gender. And then legal changes are usually, harder to enact, take more time, changing the gender marker on your legal documents or your driver's license, legally changing your name, things like that. And then medical is the part that a lot of healthcare providers are, more interested in because it's more relevant a lot of times to how people are as far as like interacting with healthcare providers and the medications they're taking. And so it can be hormones, it can be plastic surgeries, it can be mastectomies, orchiectomies, or other surgeries to align the body with the gender identity. But I put in bold at the bottom, like none of these need to be pursued. Like transition does not need to be pursued in order for a person to be transgender. A lot of these, especially the medical and legal ones, take a significant amount of resources. And if a person is not in a safe place as far as their life and resources and social safety, it might not even be safe to change how they dress or to disclose that they are transgender. So just keep that in mind. For the medical providers in the room, including like nurses and other people who work in medical environments, gender affirming hormonal medications can include any of the following. So estradiol or estrogen, progesterone is less commonly used, but it definitely is still used with trans women. Testosterone as well for more transmasculine people or transgender men. Spironolactone, it blocks testosterone. So a lot of times you'll see that in patients who are assigned male at birth, and we'll talk more about that term, or who are trans women. And then gonadotropin releasing hormone agonists are also sometimes used with transgender women. So think those are less common though than the estradiol and the testosterone. This is another note for medical providers. I always get a lot of questions when I'm talking about queer issues, especially trans folks with medical providers. They're like, well, why should I write that their sex is female if, you know, they have a prostate and they were born a man? The World Professional Association for Transgender Health has a really great section in their Standards of Care 8, which was released end of 2022. And they talk about doing an organ inventory. And it's really, really easy during a surgical history to get an organ inventory because you can say, okay, I know lots of transgender patients have had gender affirming procedures. Do you still have X organ? Do you still have Y? Have you had a mastectomy? Have you had your testicles removed? Because these things can change, like cancer risk. You know, trans men still have cervixes usually, and so trans men still need pap smears. And those are things that are sometimes lumped in with, you know, other kinds of care, like yearly care. But people who are assigned male at birth, you know, they still need to have a PSA checked after a certain year, a prostate specific antigen to screen for prostate cancer. So these are just things that, you know, rolling it into your interview when someone discloses that they are transgender can make it seem less like you're interrupting your normal flow of care and that you're just sort of rolling it into your normal interview. This is always the slide. This concept of toxic curiosity is a really, really wonderful one. And I'm going to attribute it to a therapist named Lucy Fielding. She's actually out in Waynesboro, Virginia. She wrote this incredible book called Trans Sex. And I highly, highly recommend it for medical providers and mental health providers. She talks about the experience of being a transgender person and interactions with healthcare providers and how healthcare providers often ask questions that aren't necessarily relevant to care. And it's not out of being purposefully harmful, but it ends up being harmful curiosity because it's not appropriate in that context. So whenever you have the urge to ask a question and there's a sense of you that's like, this might be really invasive, or you feel uncomfortable with something that you need to ask, it's always helpful to consider why you're asking it. Is it because it's going to change the plan of care? Is it because I need to understand this better for this patient? Is it to develop a rapport? And to always be open with patients that if they don't feel comfortable answering something, they can always decline. And you can always preface a question with, you don't have to answer this if you're not comfortable, but and it sort of addresses the power differential in the room, because whenever we are in a professional capacity interacting with somebody, we inherently have more power. And we don't ever want to intentionally or unintentionally lord that over people when they're used to having bad experiences in medical or administrative environments. Why is any of this relevant? Why do these concepts matter to medical providers and people working with families? Like, why do we care about pronouns? When are we going to use this information to know about gender affirming healthcare? I promise you, it's going to come up in your patient interviews. It's going to come up for your nurses in your care planning. It's going to come up when you're giving care directly to people. It's going to affect how your office staff talks to patients and if they use the correct name. It's going to come up when patients need to be advocated for with other providers because they're maybe not getting treated as well in another clinic or in a collaborator's office. And also when doing risk assessment and knowing what sorts of things the queer community is more affected by because of oppression and discrimination. I'm going back to the social determinants of health and how that changes the health burden on the queer community. The one thing that everyone has generally heard of is gender dysphoria, which is distress due to the discrepancy between one's body and one's gender. And this is a mental health stressor unique to transgender or non-binary individuals. It is a diagnosis in the DSM-5, but I will say that this is not a required condition. It is not required that somebody be dysphorically distressed by the discrepancy between their body and their gender in order for them to be transgender. Someone can recognize a discrepancy and be okay with it and still be transgender. It used to be conflated that gender dysphoria was sort of the administrative hoop that needed to be jumped in order for people to get gender affirming care. But there's more and more recognition that this is not required and that people should not have to meet this diagnosis in order to get a referral for gender affirming healthcare, like with a trained primary care provider or an endocrinologist. A lot of the queer community has a history of trauma, especially related to stigma and discrimination. And with that individual trauma, but also the collective trauma of knowing of the homicide risk, especially for transgender individuals, the risk for being murdered because of being so obviously different at times. I've definitely seen in my own practice patients who have some symptoms of post-traumatic stress, even when they have not individually been targeted. I practice in Virginia and Idaho, and I would say that Idaho is definitely a more hostile environment for a lot of the queer community. I've had patients witness friends in the community who've been, violently attacked, things like that, things that haven't happened to them, but have definitely impacted them. And there's an awareness that there's often a target on your back as a member of the queer community in a way that a lot of other folks are not necessarily always aware of. A lot of people, when they disclose that they are queer or that they are trans, there's a lot of falling out with family of origin. And so that a lot of queer people have decreased social support and thus resilience because it decreases like emotional support, financial resources, things like that. The statistics around substance abuse and the queer community are really disheartening. Queer folks are about twice as likely to suffer from a substance use disorder. They're also at much higher risk of cigarette smoking and tobacco use, which are very, very impactful when it comes to pregnancy and infant outcomes. Mental illness is not inherent to the queer population, but rather inherently higher in any population facing higher rates of discrimination and oppression. While many institutions officially protect gender and sexuality statuses, discrimination can take a lot of subtle forms affecting treatment in medical environments, lots of trans folks in particular report avoiding seeking emergency care often because of how poorly they are treated. And sometimes there's even like abuse in medical environments. Sometimes housing opportunities are revoked when people are found to be transgender or of the LGBTQ minority. A lot of people struggle to find workplaces that are accepting. And then there can also be repercussions where people are discriminated against in divorce and custody legal proceedings. There's a lot of data supporting that queer individuals will avoid care environments, not just ERs, but also primary care out of anticipation of poor treatment, which is a snowball effect because primary care is where we do a lot of preventative care. And if we're not getting preventative care, we're not catching problems until later on, and then it's more secondary care. I'm not actually going to play this video. I think it's a very thought-provoking and intimate look at one very famous actress's experience of her gender. Her name is Ruby Rose. Many of you will know her from Orange is the New Black. The video has no words. There's no speaking. It is very poetic. It is very intense. I'm not going to make us all watch it here, but I will recommend. It's called Break Free by Ruby Rose, and it's on YouTube. And I think it's a fantastic portrayal of what it's like to be transgender and to have a mismatch between how people expect you to look and perhaps behave based on the body you were born in, and rather what it looks like to present yourself in a way that feels authentic. I know I've been talking a lot for a really long time, so I want people to, can we look at the questions who are in the Q&A right now, Tiffany?
Yeah, I'm not seeing any questions in the Q&A just yet.
Okay.
But folks, feel free to put any questions that you may have in there. Oh, there's one question. Oh, it's about the author from Waynesboro. They're asking what their name is.
Lucy Fielding. I will write it in the chat. Or can I write it in the Q&A? Okay. Lucy
yeah, you can put it in
Fielding.
the chat.
Lucy Fielding is an LPC who I think she's also a sex therapist now. She was in training through ASECT a couple years back, but I think she's officially a sex therapist now. She focuses on the LGBTQ community as well as alternative sexuality like kink and non-monogamy. She's really, really brilliant. She's a second career therapist, so her background is in like French literature. And so her book, Trans Sex, I'm gonna write that in there, is such a fascinating, teeny tiny book, but so fascinating in how she talks about how people won't mean harm, but they will ask questions, especially about people's genitals and about whether or not they've had genital related gender affirming surgeries, which is often not related to what they're presenting for care. Like people who go to the ER and have like a terrible respiratory infection, but then they're suddenly being asked questions about like their gender and their surgeries. And I know a lot of us here are going like, oh my God, who would do that? But it happens so, so often. And it's just because as medical providers or mental health providers, we're used to asking questions. It's just a part of our job. And we're not often confronted with, well, like, should we be asking this? And so it's really, really important. And I highlight that topic of toxic curiosity pretty hard because I feel like it's important for us to be aware of. I have some.
I think a question that I hear a lot of people asking is, what do I do if I've made a misstep? If I've said something inappropriate or offended someone, how do I handle that situation?
Genuine apologies in private, I feel like are often the best way to go. I feel like drawing attention to something that you've done wrong in front of a group makes the queer person's response like sort of under a microscope. Forgive my cat. I think that in private, acknowledging the harm, people understand that intentions are almost never bad, but despite what intentions are, impact is really what matters. Forgive me. She's convinced she's a therapy cat. Acknowledging like where you went wrong and what you're going to do to avoid it from happening in the future. Reiterating that if you misstep, you are open to hearing that, and so that you can do better in the future. I think those are all things that go a really far way. So genuinely, like, good apologies, but in private, and not harping on pronoun missteps, because I know lots of people can feel really frozen once they recognize that they've made a misstep. And then it just like sort of compounds with their discomfort and like wanting to urgently address it, but it might not be the right time. And so just recognizing that offline and brief is better is the advice I usually give.
Thank you. Thank you. That was it. That was helpful.
And I wanted to point out some of these resources. There's LGBTQhealtheducation.org that has a really great part about affirmative care for non-binary people. So people who don't identify exclusively as male or female, so they could be gender fluid, agender, gender queer, you know, there's a lot of different terms that fall under that non-binary umbrella. And then the second one is probably the most important for like medical providers. WPATH is the World Professional Association for Transgender Health. They're the ones that publish the standards of care for transgender folks, both from a surgery, hormone, mental health care status guideline. And their last standards of care was 8, and it came out in September of 2022. And that is a free document on their website. So if anybody has any questions about that kind of care, there's information in there. I feel like that's especially important for people who are taking over OBGYN care for someone who's trans, who's had maybe hormones or surgeries, because being aware of like how those surgeries can be affected in the rest of the body, like changes from hormones like testosterone, which can trigger things like PCOS, which impacts fertility, like for as long as that's still affecting someone. And so it's just like really good information that is still relevant to OBGYN care and pregnancy, as well as if people have had like total mastectomies and then like breastfeeding is no longer really an option. And then there's a nurse-specific training here at rhnursing.org that is specific for nurses. And I saw that we had a lot of nurse educators in the room. So that might be a great resource for them if there's a place at Bon Secours that's really covering this content. But generally, a really good resource for information on gender and sexuality is the Planned Parenthood website. They are really, really thorough. And Planned Parenthood in Virginia is also a provider of transgender care. So if you ever have people who are new to the area or looking to establish care as far as gender affirming care, Planned Parenthood is always an option. If we don't have any other questions, I think we can probably wrap it up.
Yeah. Are there any other questions? You can feel free to put them in the Q&A. If not, then I would like to thank you so much for coming and sharing with us today. Sorry. Thank you for coming. I'm sorry. Yeah, it threw me off because I think your screen was sharing my face. And
Oh, I'm so sorry. I didn't realize that I had moved that. I was shifting things so that my mistake.
But yes, thank you for coming and sharing with us. And we're looking forward to the rest of the series. So if you haven't had a chance, or if you got this sent to you from someone else, from a colleague or something, please feel free to register. There are 4 more parts to the series, and we're looking forward to each one of them, in addition to our regular monthly webinars. So please register for the remainder of the series. And if there's no other questions now, thank you guys for attending, and we look forward to seeing everyone again.